Okay. Oh wait, we don't want to do that yet though. Okay. Okay, so welcome everyone. I'm Dr. Emily Price, a fertility specialist at TasIVF. I hope you're all comfortable in your own environment and we can have a bit of a chat today about fertility. You'll all be at different stages of your journey to parenthood. Some of you may already be parents and trying for a second or third child. Some of you may not yet be parents, and hopefully this session gives you some background information and potentially answer some questions that you might have, as well as provide some initial answers, as well as give you an avenue for seeking help if you need to. I will start tonight by explaining a bit about the reproductive anatomy and the common things that can cause problems for couples when they're trying to get pregnant, when obviously a lot of people think that this is something that will happen quite quickly and whenever they're ready, but it's not uncommon for people to run into troubles. I'll explain some of the reasons why pregnancy may be delayed, how we might investigate that, and then some of the ways that we might facilitate starting your family. Some of those options may be fairly simple methods, and some people may need to move on to IVF. But even though we are TasIVF, not everyone needs IVF treatment to start their family. Our team at TasIVF comprises of 6 fertility specialists, of which I'm one. Our medical director is Dr. Bill Watkins, and we're part of the leading group of IVF clinics in the country, partnered with IVF Australia in New South Wales, Melbourne IVF in Victoria, and Queensland Fertility Group up in Queensland. We have a fertility clinic in Hobart, as well as Launceston, and consulting at times up in Devonport. We might start by just having a chat about pre-pregnancy health, and whilst our general health is really important for our long-term health, maximising pre-pregnancy health is really important, both prior to getting pregnant but also during pregnancy. A couple of the things that we commonly talk to patients and couples about is the intake of coffee, alcohol, smoking and other drugs. We know that safe levels of coffee are, moderate levels of coffee in pregnancy and pre-pregnancy are safe. So drinking 1 to 2 cups of coffee a day is perfectly fine, as long as you don't have any other health conditions that may mean that that's inappropriate. We know that safe alcohol levels, so drinking a couple of times a week, not binge drinking and having a number of alcohol-free days a week is safe pre-pregnancy. We don't know of a safe level of alcohol in pregnancy, and so recommendation is for no alcohol in pregnancy. And particularly for men, we advise that moderating alcohol intake is important for sperm health, because we know that men that have increased and above safe levels of alcohol intake have lowered sperm counts and measures of sperm health, and so that can certainly impact on fertility. We recommend that both women and men trying for a family maintain a healthy diet, and that doesn't need to be anything too prescriptive or restrictive, but a varied diet with minimising processed foods, minimising sugar and refined sugars, and eating a wide variety of fruits and vegetables, meats if that's something that you normally would do, and making sure that we maintain the right nutrient intake via the diet. We recommend that moderate level exercise is undertaken for our general health, but particularly in fertility, we understand that that exercise has many benefits for people, both in their physical as well as their psychological health. We understand that there are some people, in fact, who exercise is a big part of their life, and in fact, sometimes that can have a negative impact in their fertility. So it's about balance and having moderate levels of exercise without overdoing it and without being too sedentary. We all know that smoking is not good for our general health, and in particular, it is a significant risk factor for impaired fertility, as well as for risk factors for pregnancy complications and risk of medical conditions in the offspring, so in the children born. We understand that men who smoke have reduced sperm counts, reduced other measures of sperm health, so motility and morphology, meaning the shape of the sperm, and have increased rates of subfertility in their offspring. We also know that women who smoke have lowered rates of fertility, increased risk of pregnancy complications such as miscarriage and preeclampsia and high blood pressure in pregnancy, growth-restricted babies. And so, in addition to the longer-term health impacts of smoking, we certainly recommend that all couples who are contemplating pregnancy try to quit smoking. And certainly your health professionals can help assist you with that if it's required. We recommend that women and men trying to start a family maintain a healthy BMI. Now, BMI stands for body mass index, and it's a mathematical calculation of ratio of height to weight. And overall, we know that that maintaining a healthy BMI can help to improve reproductive menstrual cycles for women, improve spontaneous ovulation rates, and improve spontaneous pregnancy rates. For men, it improves parameters of sperm health, and overall it reduces the risks of complications to women in pregnancy if they maintain a healthy BMI, which is it's classified between 19 and 25. We do recommend that women don't have too prescriptive diets or exercises mentioned previously, but maintaining weight within a healthy range is appropriate and recommended. I guess one of the questions that people often ask is why is this happening to us and are we alone? But actually, infertility and subfertility is actually relatively common, with 1 in 6 couples needing assistance conceiving. And it can be for a variety of reasons, and it can be female-related, male-related, a combination of both, or in some cases, up to about 15% of times, it can be unexplained. For women, there are a number of reasons why they may be finding it difficult to get pregnant, and similarly for the men. And we might go into that in a little bit more detail just going forward. One of the things that people wonder about is what happens when I come to see a fertility specialist. Well, initially what we would recommend you do is you seek referral and seek advice if you've been trying to conceive for over 12 months if you're 35 years or older for the woman, or if you've been trying to conceive for 6 months if you're 35 years or older, or for 12 months if you're under the age of 35. And we have that difference between the age groups because we know that as women age, the number of eggs left to create a pregnancy and the time left to create a pregnancy is reducing. At the first appointment that we have, we would review your complete medical history and fertility history, so history of any previous pregnancies, either together or with previous partners. Assess your general health, so look at other health conditions that can impact on pregnancy, such as high blood pressure, diabetes, thyroid dysfunction. Assess what your menstrual cycles are like for the woman, so if there's any symptoms suggestive of reproductive issues like endometriosis or polycystic ovarian syndrome. For the man, assess lifestyle, so weight, smoking, alcohol intake, any occupational exposures that may impact on fertility, and any previous surgery or illnesses that may impact on sperm production. And then depending on your history and the history of your subfertility to the point of having your first appointment, arrange fertility tests as appropriate to you as a couple. There's a general panel of investigations that we would generally organise for most couples, but then there will be tests that will be specific to you as the individual. At the first appointment, we may be able to discuss possible treatments, but it also may be appropriate to wait for the results of investigation so that we can further tailor your treatments to the needs of you and your family. When we talk about investigations, we need to think about the basics of what we need to create a pregnancy. And it might seem silly talking about it, but there's, excuse me, there's certainly some basics that we need. And we need eggs that are released from the ovaries at the right time. We need sperm that is moving, that is healthy, that's in an adequate number to create a pregnancy. We need intercourse at the right time of the month, so at the time that ovulation is about to occur or is occurring. We need normal anatomy for both the male and female so that one, sperm can reach the eggs, and two, that eggs and sperm together as a fertilised embryo can then move back into the uterus and implant to then create an ongoing pregnancy. And so investigation forms part of determining which, if any, of these issues may be contributing to your difficulty getting pregnant and how we may best help you depending on what that abnormality is. For our women, you may actually be surprised to know that we're actually born with the most eggs we'll ever have. So when we're in our mum's tummies at about 4 to 5 months of pregnancy, we have the most eggs we'll ever have. We've got about 4 million in our ovaries. By the time we're born, we've got about 1 to 2 million. By the time we reach puberty and start having our periods, at about 12 to 13 years of age, we've got about 400,000. And we only ever ovulate about 400 in our lifetime. Being on the pill, using other medications, being pregnant or breastfeeding previously doesn't impact on the rate at which you lose eggs. They are being lost at a steady rate for all women, some faster than others, but it is certainly something that is an unavoidable aspect of being female. And it's something that a number of women don't necessarily appreciate, or a number of couples don't necessarily appreciate, and is one of the difficulties of our modern society, in that women and families are deferring childbearing until later in life. And it's something that we can help educate women and couples about, and actually assess what the ovarian reserve level is like. So we've got a number of tests to look at both ovarian function in terms of whether the eggs are being released each month, whether ovulation is occurring, and also looking at the ovarian reserve, so looking at how many eggs are left. And so a number of you may have already had a test with your GP or with your fertility specialist, or may not yet have had one, called an AMH, an anti-Müllerian hormone test. So anti-Müllerian hormone is a hormone released from the ovaries, from the cells surrounding the early eggs, that is used as a surrogate marker of how many eggs are left. It doesn't give any assessment of the quality of those eggs, which we know does decline as women age, but it does give an assessment of the ovarian reserve and how many we may be able to safely retrieve should we need to, and how likely it is for fertility medications to work. The other thing we need to do is to look at assessing ovulation. Often for some women, they're having very irregular periods, so every 35 to 60 days, or very short cycles, less than 25 days. Sometimes those women, or quite often those women, are not ovulating, or they're ovulating very infrequently. And it's no surprise that that can be difficult to determine when the right timing is to have intercourse to then create a pregnancy. And so sometimes we can provide treatments to improve the rates at which women ovulate, as well as provide guidance on the appropriate timing for intercourse, potentially by just tracking a woman's cycle. Some of you may have already been using urinary ovulation predictor kits, or OPK, which are sometimes a little bit tricky to navigate the instructions, but are usually a very accurate way of assessing when a woman's almost imminently ovulating. And so the best timing for intercourse is within the 24 hours after a positive urinary ovulation prediction. Some women may have already had a blood test in the second half of their cycle, either through their GP or fertility specialist, to assess whether they're ovulating, looking at the blood progesterone level. And that's an assessment of whether there's progesterone being released by the ovary post-ovulation. And those are some of the tests that we might also do when you first come in to see us for an assessment of your fertility, to see whether we can determine what the problem might be. One of the other things for most women coming in for an assessment of fertility is to look at the pelvic anatomy. And so for an assessment of whether women may have a blocked or damaged fallopian tube or tubes, to see whether there's any evidence of polycystic ovaries, whether there's any evidence of severe endometriosis, bearing in mind that mild to moderate endometriosis is commonly not identifiable on ultrasound and may be more commonly diagnosed either on history or on laparoscopy, which is a surgery. Looking at whether there's any evidence of fibroids in the uterus, either in the wall or in the uterine cavity, and looking at whether there's any evidence of failure of ovulation. Some women will be recommended or will have already had, when they come to see us, a test to assess whether the tubes are open or not. And some women who have a history of endometriosis or pelvic infection, either from a history of something like a ruptured appendix or pelvic inflammatory disease in the setting of infections like chlamydia, do have increased risk of tubal blockage. And so a tubal patency test is important for some couples to assess whether more simplified treatments for subfertility are appropriate, or whether, if there's tubal blockage, whether a treatment like IVF is more appropriate to bypass that blockage. For men, we also need to do some investigations usually, and the most important test for a man is usually the semen analysis. Now, the chart that you can see on the slide is quite an old chart when some inmates had their samples tested to see what the variation was in the semen analysis and the sperm count over many months. I don't quite know what happened at the start there. However, generally you can see that there's a rough sort of a distribution of normal for the sperm concentration for the men that were sampled. And so when we get men to do a sperm assessment at TasIVF, in our laboratory we look at the number of sperm in the sample, we look at the volume of the sample, we look at how the sperm are moving, whether they're moving forward or whether they're moving in circles or in other ways that may not necessarily be particularly helpful for achieving a pregnancy, whether they look normal. And in fact, we know that the majority of sperm will not have a 100% perfect normal appearance, but that actually we only need about 4 to 5% of them to be normal to be able to achieve a pregnancy. We look at whether there's any evidence of anti-sperm antibodies, which can be more common in men who've had a history of testicular surgery, testicular trauma, a reversal of a vasectomy. And that's something that we need to assess to determine whether, in fact, whether the body is creating antibodies to prevent pregnancy occurring because of this previous trauma. You can see on the next slide just a couple of the issues that may occur because of an abnormality on the male fertility test. So we may see that, in fact, there's a very low sperm count or poor sperm movement. As we said, there may be a high number of abnormal sperm. We talked about anti-sperm antibodies. We may find that actually for a man who, for all intents and purposes, has never had any trauma or surgery and appears to have a normal ejaculate, actually has a blocked or absent vas deferens. And a vas deferens is basically the tube that connects the sperm to the outside world. And if we can't actually get the sperm out, then that's obviously a cause for subfertility, and something that's actually reasonably easy to navigate and to treat. And occasionally, very rarely, we see that there's a complete failure of sperm production, either because of hormonal imbalances or other medical conditions. And sometimes that's amenable to treatment for that man, and other times we need to use other options for treatment, such as our donor sperm program. There's also some other additional tests that we may do for couples that come through for workup of subfertility. We look at a basic carrier type, so looking at the number of chromosomes that each person has, and then sex chromosomes. We know that a small proportion of the population will have an abnormal carrier type, which doesn't necessarily cause a problem for them, but can cause a problem when they're then trying to create a pregnancy with someone else and the chromosome count is unbalanced. We would routinely do a pre-pregnancy infection screen for most women, which looks to assess the immunisation or vaccination status for common things like German measles, rubella, or chickenpox, which is known as varicella, because these are things that are amenable to vaccination prior to pregnancy. We would most likely also talk to you about options for genetic screening for common conditions such as, or common carrier conditions such as cystic fibrosis, spinal muscular atrophy, and Fragile X, as well as a number of other genetic conditions that we can now screen for with a simple blood test or cheek swab, and provide further information if families or couples are found to be at risk of having an affected child, where treatment with IVF and genetic screening of the embryos may be appropriate. So I guess the next step is to move on to what treatment options may be available. So often, and particularly for younger couples, it may be appropriate to wait and allow time. We know that the majority of couples within the first 12 to 18 months of trying to get pregnant will actually spontaneously conceive. We understand that it's very frustrating at times, particularly with work, life, travel, that the stress of trying to get pregnant is not to be underestimated, but actually that some people and some couples coming for an assessment and potentially reassurance is all that is required. As mentioned previously, it may be appropriate that some lifestyle modification is undertaken. So appropriate weight management, quitting smoking, moderating alcohol intake, minimising any other medications or addressing medications that a woman or man may be taking that may have an impact on pregnancy or embryo development or fetal development, to optimise their chances of having a successful pregnancy and a successful pregnancy outcome and starting their family. We may start with things, simple measures such as cycle monitoring. So tracking a woman's cycle using ultrasound, potentially some blood tests to determine when she may be ovulating, to determine if there's any issues with the development of the egg follicle, to look at whether there's any issues with the development of the womb lining, and to guide appropriate timed intercourse. Occasionally we use a medication to help trigger ovulation, which can help facilitate this timing. Sometimes we would offer surgery for things like treatment of endometriosis, for correction of any pelvic scarring that may be there, removal of fibroids if it's appropriate or likely to have a positive impact on fertility, for investigation of the uterine cavity, such as looking at removing endometrial polyps or resecting a uterine septum, and sometimes for investigation of unexplained infertility when we're looking for answers. We may move on to ovulation induction. So for women who are not ovulating or who are ovulating very irregularly, we quite commonly look to starting some very well tolerated medications with a low side effect profile, which are very effective in inducing ovulation in over 80% of women. We commonly use oral medications, and most commonly letrozole, which is a tablet used in the first few days of the cycle, to induce ovulation, and we monitor the cycle then with ultrasound and sometimes blood tests to further then facilitate the right timing for intercourse. Sometimes we use injectable medications to induce ovulation also, which is obviously becoming more complex, but is also a very effective treatment for inducing ovulation. For some couples, particularly with unexplained infertility or mild tubal disease, only unilateral of course, for mild endometriosis, particularly for younger women, or for women who are having donor sperm. So for women who are solo parenting or who are in a same-sex couple and donor sperm recipients, we can perform intra-uterine insemination. And that can be part of a natural cycle or a cycle where we've had ovulation induction, as previously mentioned. And it basically involves putting prepared sperm into the uterine cavity at the right time of the month. It's more successful in younger women and achieves a pregnancy in between 5 to 15% of cycles, depending on the indication for treatment. There's minimal medications involved in the cycle, but there obviously is some monitoring associated with it. But it is certainly appropriate for some patients and couples, depending on their cause of their subfertility. And so I guess we'll move on to a little bit of information about IVF and ICSI, just so you get a bit of an understanding about the process, even though it's not necessarily appropriate for all couples. So IVF stands for in vitro fertilization, and ICSI stands for intracytoplasmic sperm injection or microinjection of the sperm. The process of IVF and ICSI up to the point of fertilization is the same. And so women undergo controlled ovarian stimulation, so with injectable medications in the first week of the cycle, and ultrasound monitoring to assess how the ovarian follicles are developing. And the aim, as opposed to a normal cycle where we aim to produce one egg and release one egg per cycle, we aim to recruit multiple eggs per cycle. And the number of eggs recruited varies from woman to woman, and particularly varies by age and by the level of ovarian reserve that each woman has. The eggs are collected under ultrasound guidance and then taken to the laboratory where they're fertilised by the treatment method appropriate for that couple. In IVF, an egg with 50 to 100,000 sperm are combined and allowed to fertilise in the dish, whereas in microinjection we take one egg and one sperm, and the sperm is microinjected directly into the egg. We may use ICSI where the sperm is lower grade, or where there's been problems with traditional IVF, or where there's particularly insufficient numbers of sperm to provide adequate fertilisation in traditional IVF, or where we've retrieved sperm via a testicular biopsy for men who may have had a previous vasectomy or have insufficient sperm retrieved through ejaculate. If the decision has been made and that IVF is an appropriate treatment for you, the process involves a number of different steps with support along the way from the nursing staff, the laboratory staff and the clinical staff involved in your care. So initially you'll have orientation with a nurse who will run through with you the routine cycle monitoring, how to give medications, what to do if there's a problem, who to call and how to contact them, as well as be your contact should you need any help throughout your cycle. You will start your hormone stimulation within the first few days of your cycle, and then have, as discussed earlier, have some monitoring with ultrasound and potentially blood tests over the next 1 to 2 weeks. Usually at around the 2-week mark, we have an egg collection performed under ultrasound guidance with either some pain relief and inhaled nitrous, which is a happy gas, so a pain relieving gas, or with some sedation given by an anaesthetist. As I said, the eggs and the sperm go to the laboratory for fertilisation in the method that's determined to be appropriate for you. And then the embryos that are created are grown in the laboratory for up to 3 to 5 days before being either transferred into the uterus, usually one at a time, or frozen for use later on, either planned or if there's excess embryos. You can see on this slide the development of the embryos And you can see on the first day of fertilisation, within the first 24 hours of the egg and the sperm being together, you can see that the internal cells are starting to divide. And you can see the progression over days 2, 3, 4 of those cells rapidly dividing. They then start to compact down on day 4 before expanding on day 5 and forming what we call a blastocyst. The blastocyst on day 5 to 6 starts to hatch, and it's at that stage that embryos are normally implanting in the uterine cavity in the natural environment. I think it's important for people who are contemplating IVF or trying to understand the process of assisted fertility to understand what happens to the eggs that are retrieved, because not every egg that we retrieve under ultrasound guidance will go on to develop into an embryo, and not every embryo that will be transferred will go on to create a pregnancy or a baby. In the lead up to egg collection, we know that we'll be monitoring your cycle, and so we can get an understanding of how many eggs are likely to be retrieved at egg collection, whether that's an average number, and usually we aim for somewhere between 10 to 15 eggs, depending on the patient, or whether that number is higher or lower. When we look at an average, and I usually like to use 9 or 10 for ease of reference, of 9 or 10 eggs that are collected, we understand that about 7 of them will be mature and about 6 to 7 of them will fertilise in the laboratory. We know that on day 4, on day 3, we will see that we've usually got 4 to 5 of them that are viable embryos at that stage. And by the stage of day 5, we usually see that we've got 3 to 4 of them that are viable embryos or blastocysts. And so we can see that on average, about 30% of retrieved eggs will develop into blastocysts on day 5 for either transfer or for freezing. And that's a normal process and normal outcomes. For some couples, as I mentioned earlier, we know that they will require donor sperm. And that, as I said, is for women who may be choosing to solo parent or for women in a same-sex relationship. We've got a very comprehensive long-running donor program with a dedicated donor coordinator, and who basically coordinates sperm donation, embryo donation, and egg donation. All 3 of those may be anonymous or known. As in, a couple may have a donor who is willing to donate sperm to them, for instance, or they will want to utilise our anonymous program. There are certainly obviously legal and clinical prerequisites for the program, but certainly if you're at all interested, then a starting point would be to make a donor inquiry via our website, and our donor coordinator will get in contact with you as required. When we look at our IVF success rates, this data is a little bit old, but it's still appropriate. We know that the cumulative pregnancy rate is a really good measure of success. We know that for younger couples, actually, they're quite likely to achieve a pregnancy, and in fact, over 50% of cases will be likely to achieve a pregnancy in the first cycle. That doesn't necessarily mean after the first embryo transfer, but it means in the first IVF cycle. We can see that over time, the cumulative pregnancy rate increases quite significantly, although it does differ by age bracket. Once pregnant, the percentage of women achieving a live delivery according to age is about 94% for women under 35, 86% for women between 35 and 39, and 80% for women over 39. So once pregnant, the live birth rates are excellent. So why choose TasIVF? Well, we've got a very good network of care. So we've got local, national, and global connections through the umbrella of Virtus Health. We're very proud to be the state's first fertility provider, and have been helping to conceive about 1 in 23 births in the state since we started. We've got expert scientists who've been working at TasIVF for many years, and a very, very experienced nursing team with many years of experience amongst them. We've certainly got a comprehensive donor program, as mentioned previously, and as I said, anyone that might be interested in that should make an inquiry on the website. And coming in 2018, we've got a state-of-the-art brand new facility that will be built in central Hobart. You may be interested to know what the costs of care at TasIVF are, and obviously they are unique to your specific situation, but I think having some information is useful. We know that an initial consultation costs approximately $240. Investigations are usually individualised and so may have some associated costs depending on your situation, your health insurance, your Medicare safety net, for example. The treatment cycles do vary by the number of cycles you've had already in that year, or any other medical treatment that you or your partner may have already had that year. But an intra-uterine insemination cycle costs approximately $396 out of pocket after the Medicare rebate. An IVF cycle, a standard IVF cycle, which involves sedation in theatre for your egg collection and an admission to the hospital for that purpose, is about $1,700 out of pocket, depending on your Medicare safety net. We also have a low stimulation model of care, where we aim for slightly lower egg numbers, which facilitates women being able to have their egg collection without anaesthetic and negates the need for hospital admission costs, and so is appropriate for some people who may not have private health insurance, or may have medical indications for avoiding an anaesthetic, or have known low egg numbers, and so that's an appropriate method for their treatment. The final out-of-pocket costs for those cycles vary between about $1,000 and $2,000, depending on the Medicare safety net prior to that. And obviously your individual circumstances will determine your final out-of-pocket costs. There's potentially theatre costs associated depending on your health fund cover. And we're very lucky in Australia with federal government support of high-cost medical and scientific services related to IVF. So we do attract Medicare rebates. But all costs are detailed prior to commencing treatment so that you understand what your treatment is likely to involve. So next steps. I hope you've all found this a little bit helpful for you on your journey towards starting a family. You may have some questions, so we might move on to answering some questions if possible. If appropriate, or you feel the need, we'd like to chat further. It'd be great to meet some of you, so make an appointment. Ideally get a GP referral first so you can get a Medicare rebate. And we can help you make informed decisions through options and advice that are specific to you and your family and your individual situation. So we might move on to answering some questions. And I've got one question here that says, if a female did have tubal blockage that hasn't been cleared, would pregnancy and childbirth correct this? And I'm assuming that we're talking about someone who's got complete tubal blockage. So for instance, from a condition like endometriosis or previous infection. And if we've got documented complete blockage, pregnancy and childbirth specifically won't correct this. However, there are a number of different options for treatment. Depending on where the blockage is, it may be appropriate for surgery. And so for treatment of the blockage, particularly if it's at the distal or the end of the tubes, or if the blockage is complete and not amenable to surgery, then certainly IVF is an option. And in fact, that's why it was developed in the first place, was for for women who had tubal blockage, particularly in the setting of previous infection. If we don't have any other further questions there, we might leave it at that. I hope you've had a comfortable and informative webinar tonight. We thank you for joining us. I hope I've helped answer some questions, put some things into perspective about how common this is and what things might be contributing to any difficulties that you might be having. We are certainly available if you'd like to come and chat one-on-one, and our nursing staff are always available to answer questions as well. So I'd love to see some of you if required. Okay, take care, have a good night.